And you're in for a real treat tonight. Dr. Banik has done, this is your third lecture this year. But she's done other lectures, and we always sort of run out of time a little bit for questions because there's so much content. So I want to go ahead and get started. I know there might be some people that join us late. I'm going to let you talk a little bit about your field and your expertise, if you can do your little bio, because I don't want to take too much time. But thank you for coming. Thank you so much for your time, and we'll begin. How to conquer your headaches.
Wonderful. Thank you so much, Caroline. Can everyone hear me? Yes, okay, wonderful. And I also wanted to thank the JCC for having me speak again. I really enjoyed being here. The talks are always well attended. There's a lot of wonderful questions, and I will leave some time at the end for questions, so feel free. I would prefer that you not ask questions during the talks. I can get through it all, but we'll definitely have time at the end. So as you can see, today I'm going to be talking about headaches, and specifically migraines. And I'm going to be talking about a particular type of approach to headaches. So not necessarily the conventional pharmaceutical approach, but some alternative approaches that you may want to consider if you suffer from headaches. So let's get started here. Okay, so before I actually begin my talk, I'd just like to know by a show of hands, how many of you in the audience suffer from headaches or migraines? Okay, so the majority. Now, how many of you are here because perhaps you have a loved one, a family member, a friend, a neighbor who suffers from migraines? Okay, so a couple. And okay, so if you do suffer, or if you know people who suffer, how frequent are your headaches? For example, are they more than every 6 months? Yes? Okay. How about more than once a month? How about every week? How about every day? Okay, so I'm going to join that group because I actually suffered from headaches every single day for a period of time, and I'm going to tell you my story. So a couple of years ago, about 5 years ago, I was going through a very stressful period in my life, things at work, things at home, and I was not sleeping properly, I wasn't eating properly, and my headaches, I'd always had some mild headaches, but they became very, very severe. So basically, I would wake up in the morning every single day with an ice pick going through my head. And I'm seeing some heads nod, so I'm not alone in this symptom. And basically, I would have this headache all day long. It would vary. Sometimes it would be more intense, sometimes a little bit less. Sometimes it would be that stabbing headache. Sometimes it would be like a vice, like someone was squeezing my head, like a tight band or vice around my head. But basically, I experienced this every single day. And I had to go to work with this headache. I had it during the work week. I had it on weekends. And the ironic thing was I was taking care of patients with headaches. So I am a neuro-ophthalmologist. I am an ophthalmologist, but I have fellowship trained in neuro-ophthalmology. And I would say about 50% of my patients have headaches. So here I am with headaches myself, trying to take care of these patients with the same types of symptoms. And so, being in New York City, I went to all of the top headache doctors I could find. I went to Cornell, I went to Columbia, I went to NYU, I went to Mount Sinai. And every time, first of all, it would take me about 3 months to get the appointment. And I'm seeing some heads nod, yes, that's true. It takes a while to get the appointment, but I would show up and the doctor would listen to me. They knew that I was a doctor, they knew I was a neuro-ophthalmologist, and they would say, oh, why don't you try this? This is the latest new drug on the market, and they would write me a script. And see you in 3 months. And what happened was I got script after script after script, and nothing was working. And either the medications, they either just didn't work at all, or they gave me horrible side effects and I could not function. I was confused, I was sleepy, I just could not function at work. And at some point, after about 2 years into this, I decided that's enough. I'm not taking any more medications. There must be a better way to fix this problem. Now, meanwhile, none of my lifestyle issues had changed. I was still doing the same thing. I was sleeping maybe 5-6 hours a night. I wasn't eating regularly. I wasn't hydrating. So all of those things, none of my doctors ever asked me, what do you do in in terms of your diet? What are you eating? How much do you? None of them ever asked me that. So I started to do some research myself, and what I found was that there is a lot out there on complementary and integrative or alternative ways to manage headaches, and none of my doctors have ever mentioned them to me. So I really began to research quite a bit, and what I realized was that I needed to find my own solution, to do some deep digging, to find where my triggers were coming from. And finally, after several months of trying this, I tried some supplements, I changed my diet, I changed my habits, and things started to get better. And I was still, in my practice with my patients, I was still prescribing medications because that's what I was taught in medical school. That's how you do it. You just write a prescription. So I was still doing that. But then finally one day I said, wait a minute, these changes are working for me. What if I try them for some of my patients as well? So I'll tell you this very brief story and then we'll get to my talk. So I had a 70-year-old patient come and see me, and she told me she'd had headaches for 50 years. And her headaches were so debilitating that she would not go outside. She was not social at all. She would just basically stay in the dark at home. And I asked her, I said, you've had headaches for 50 years. Why do you think I could help you? What made you come to see me? How did you find me? And she said, well, because my niece came to see you and she has headaches also, and you helped her. And she said that I should come see you. So what I did was I took my own regimen that I was using for myself, the supplements, the other interventions, and I wrote them down for her. And I said, look, I don't know if this is going to work. I want you to try all of these things and then come back and see me in 6 weeks and we'll see. And she came back with a smile on her face and she said, doctor, you've changed my life. And I was shocked. Honestly, I did not think that any of this would really, I didn't know if it was going to work for her, but she was conscientious about it. She did the regimen, and she said, now I can go out, I can meet with my friends, I can be social, I'm going shopping. My husband's not happy because I'm shopping too much, I'm spending too much money, because before the fluorescent lights in the stores were too much for her. She could not tolerate them. So she got, of course she was never, there's no cure for migraine. She wasn't completely migraine free, but instead of having a headache every single day, she went down to having a headache maybe 3 or 4 times a month. So, and I started to use this regimen for many of my other patients, and many of them do respond. I wouldn't say all of them respond, but many of them do respond. And so what I'd like to do is share with you today some of the strategies that I've used for myself and my patients. So with that, before I get into that, I do want to just give you a brief overview of scientifically what is migraine, what's actually happening in the brain, so you can understand it a little bit more and see why some of these interventions may be beneficial. So what is migraine? So it's interesting, in the medical community, we still don't 100% understand what causes migraines. There are theories out there, but there is no consensus on what exactly the actual pathophysiology is. But there is a theory called the Neurovascular Theory, and that's kind of taken prominence in the medical world, and that we believe that that's really the underlying problem with migraine. So what is this Neurovascular Theory? So basically, I don't know if you can read this for those of you who are in the back, but there is a cycle of events that happens, and I'll just go through very briefly what this cycle is. So number one, somewhere deep within the brain, there is some kind of a trigger. There's a stimulus, something that the switch gets flipped on, and then there's an electrical change that begins in the brain. So this is here. This is step number 2. There are electrical impulses that get sent, and they spread to certain parts of the brain. And then what happens is that these electrical impulses actually affect the vasculature as well. So that's why it's called the neurovascular theory. So the blood vessels begin to release certain chemicals. They begin to either dilate or constrict. And some people believe that initially they constrict and then they dilate. And when these blood vessels in the brain dilate, many patients will have what oftentimes precedes the headache, which is called an aura. How many of you have had an aura? So many of you probably have had a visual aura, where you see flashing lights. It looks like shimmering, multicolored, like a kaleidoscope, or lots of little geometric shapes. Usually it lasts 20 to 30 minutes and then it resolves. That's the most common type of aura that precedes migraine, but there are other types of aura as well. Some people get olfactory auras, meaning they have certain smells that they experience before the headache starts. Rarely people will get an auditory aura or tingling or numbness. So there's a range of different neurologic symptoms that may actually precede the headache. And we believe this is when the blood vessels initially constrict within the brain. The next step, which is step number 4 in this cascade of events, is that now the blood vessels, there's chemicals that have been released, then the blood vessels dilate. And when the blood vessels dilate within the brain, that's when the headache starts. Okay, there's increased blood flow, the vessels stretch, the covering of the brain stretches, and that's when people have pain. There's also inflammation associated when all these chemicals are released. And then finally, when these chemicals are released, they actually affect a specific nerve, and I'll go into what that nerve is. That's what causes the actual severe headache or the throbbing sensation many people have. So again, this is the neurovascular theory of migraine. Now, in terms of the nerve, so it's interesting, the brain is full of billions of neurons, but most of them don't actually sense pain. The nerve in the brain that senses pain is called the trigeminal nerve. And it's a nerve that comes out, in this diagram, it's coming out from very, very deep within the brain, and it has many, many different branches, and it has many different roles. So I'm simplifying things, but it goes to the covering of the brain, it gives a sensation to the covering of the brain, it gives a sensation to the scalp, it has different branches that go to the face. So for example, there's a branch that goes up to the forehead, there are branches that go to the eye socket, to the cheek, as well as the jaws, the upper and lower gum line. Okay, so it's a very, it has many, many branches, it has many purposes, this nerve, but sensory is one of the main purposes of the nerve. Now, so when this nerve gets inflamed and irritated, people may experience pain in any of these distributions. And it's not shown, this diagram doesn't show it, but imagine the entire scalp is also being covered by this nerve, or different branches of the nerve. But an important thing to realize is that there are connections between this nerve and deeper within the brain called the brainstem. And there is something called the trigeminal nucleus caudalis, which is like a relay center in the brainstem. And this relay center also gets input from other nerves that go to the scalp as well. And some of the nerves in the back of the head, branches of what we call the occipital nerve, they relay with this trigeminal nerve. So the reason I'm pointing this out is because sometimes people will experience pain that comes from the back. I don't know if any of you have experienced this, kind of the back of the head or even from the neck or the shoulders, and it radiates up, and then eventually it will come to the front or to the eye socket or to the other parts of the face. Has anyone experienced this? Yes? Okay. So that's the reason why. So this is not the nerve that primarily gets involved in most headache syndromes, but secondarily it can definitely get involved. Okay, so that's really the most scientific I'm going to get about migraine. Now, what I'm going to talk about next are some more epidemiologic features of migraine, and then we'll get into the treatment approaches that I use. So, first of all, what causes migraine? Well, there definitely is a genetic component to migraine. Now, those of you with migraine, how many of you have people in your family with migraine? Yes, so about half of you. So about 50% so if you have a parent with migraine, 50% of their offspring will be predisposed to migraine, okay? And it's interesting, the genetics are not the only risk factor, it's one of the risk factors, but there have been twin studies which show that one twin may have had headaches and migraine, may be suffering, but the other twin does not get them. So they have the exact same genetics, they're homozygous twins, but there are other factors involved. So genetics is a predisposition. There are almost, I think at the last count, about 50 genes that have been identified associated with migraine. Now again, it doesn't mean that just because you have the gene that you will have the symptom, but there is you're more likely to develop symptoms. So there are other issues that can trigger migraine. So there's the genetic predisposition, then layered on top of that are the lifestyle triggers. And so there's an evolving field of science called epigenetics. And has anyone heard of epigenetics before? Yes. So epigenetics is basically how our environmental or internal factors influence expression of our genes. So yes, the gene may be there, but what is turning the gene on or off? So this is called epigenetics. And so what this is a little bit of a busy image picture here, but this is the cell, and here's the DNA within the cell. And there are transcription factors that can be that can be affected by external factors. Again, it could be something within the body or it could be something external to the body. So, so here we have nutritional factors. So what you're eating, or perhaps you have a deficiency in something that could be turning a gene on or off. The environment is a key factor here, so there could be things that you're exposed to in the environment, for example, toxins in the environment, pesticides, perhaps heavy metals that you've been exposed to that can perhaps turn genes on and off. And I'm not just speaking about migraine here, this is true for many other conditions, but I'm just giving you some examples. Exercise, or either whether it's activity or a sedentary lifestyle, can turn genes on and off. And then emotional health, which is a big one, and we'll talk a lot more about this in a little bit. Peace of mind, whether someone's spiritual or religious, it doesn't matter, but the internal stress that someone can have can definitely affect expression of genes. And so there's research being done, not just in migraine with epigenetics, but in many other conditions. So we're just learning more about how, specifically in migraine, the epigenetics may be playing a role, but there's no doubt that it does play a role. Because again, not everyone with the gene will actually experience the symptom. So when we're talking about epigenetics, what are, I had thrown out a couple of factors, but what do you think some of the potential lifestyle triggers may be, or other internal triggers may be? Anyone? Lack of sleep, caffeine, yes. Noise, stress, right? Bad work, okay, yeah. So I'll just list a couple of them here. So food sensitivities. Some people may experience worsening symptoms when they ingest certain foods. So how many of you have had a migraine after having a certain kind of cheese? How about wine, red wine? Okay. How about too much sugar? Or lack of food? Hunger can sometimes trigger migraines. So food, as a general category, yes, food is a trigger, but certain people have certain food sensitivities. So MSG is also a common ingredient that is a preservative that is linked with migraines. So that's just some of the examples of food sensitivities. Hydration status, I mentioned a couple of times. Dehydration can definitely be associated with migraine or be a trigger for migraine. Poor sleep, the quality of sleep, the amount of sleep may be a trigger, and then musculoskeletal. So here, I put this here because sometimes patients have neck or shoulder injuries, or perhaps not neck or shoulder, but perhaps they've had a concussion, and that somehow triggers this cascade of events and it leads to migraine. So there are sometimes musculoskeletal issues that affect the occipital nerve or the cervical nerves, and then that can trigger migraine. Okay, so now what do I have here? Hormones. So hormones can play a significant role, especially in women. There definitely can be hormonal migraines. I don't know if any of you have experienced this before. Many times it's actually after the cycle begins that women experience worsening migraines, and it's thought to be changing levels of progesterone and estrogen. And we don't know for sure, but we think that it's a sudden drop in estrogen that can trigger migraines around that perimenstrual period. So definitely that could be a factor in some patients. And then toxins, as I mentioned before. Heavy metals are being investigated. There is a school of thought, there are some people, I'm not 100% convinced, but there are some people who believe that mercury, especially dental work with mercury fillings or silver fillings with some mercury, may be associated with increased risk of migraines as well. So there are many, many things to consider here in terms of the epigenetics that may be leading to migraine. And this bubble here, which is stress. Okay, again, I can't emphasize how critical stress levels are in terms of migraine. So, because I can't emphasize it, I'll show it to you like this. So I would say it probably overshadows all the other triggers. Okay, so let's move on here. So if you experience migraine, it's very important for you to be your own detective, try to figure out which specific triggers make things worse and what can make things better. So it's important to keep a headache diary or a log. And so this is one that I found, I don't know if you can all read this or even in your handout, but it's from this website, confessionsofoverworkedmom.com. Okay, so it's actually a very nice, concise chart. So when you log your symptoms, you should log the date, the time, the severity of it. So I like to ask patients, on a scale of 0 to 10, 10 being the worst that it could be, how bad is your headache? And try to log it so you can see what the pattern is. Any relationship with diet, for example, hunger or specific types of foods, try to identify that. Weather is a big trigger for some patients. I didn't include this in the other chart, but barometric changes. Sometimes for me, even when it's overcast, it may not be raining, but even when it's overcast, I know that that's going to be a bad day. So we don't really understand what is it about barometric changes, humidity, temperature, weather that triggers migraine, but definitely there is a link. Physical activity, either too much or too little. Sometimes patients will come to me after being in the gym, they've had a heavy workout, and all of a sudden they start seeing their flashing lights, and then they get the headache. So that could be a trigger in itself, not just hydration status during exercise, but physical activity itself. Sleep, as I mentioned before, it's important to include in the headache tracker, menstrual cycle and stressors. Does anyone here keep a headache diary? So has it helped you? No? Have you shown it to your doctor?
Not yet.
Not yet. You should show it to your doctor just to get a sense from another person's perspective. Maybe they can see a pattern that you're not seeing. Okay. So I mentioned before the knee-jerk reaction when patients have migraine is for their doctor to write a prescription. And there is a whole slew of medications that can be used. Many of them are not specifically migraine medications. Many of them are blood pressure medicines or seizure medicines that are also used for migraine. But many of them have side effects, as I was mentioning before. Now there's actually a couple of new drugs on the market. CGRP inhibitors, has anyone heard of them or tried them? So CGRP stands for calcitonin gene-related peptide. These are usually injections that patients may get for control of chronic pain. There's also a new class that's coming out as well. I believe it's called Geptan.
Ketamine.
Ketamine.
Is that what you mean?
Do you remember what it is? My colleague is here, so I'm asking her. But I think it's called a Geptan. But there's another new class of medicines that should be coming out, I think, later this year, or definitely in 2020. But this is basically the knee-jerk reaction. But what many of these medications actually do for migraine, unfortunately, the medical community really does not understand. So yes, we're writing these prescriptions, giving out medications, but we have no idea what they're really doing in the body. Maybe the CGRP inhibitors are more specific, though that's the only class that's very, very specific in terms of migraine, but still, most of us, we don't know. So it's basically a trial and error method. So in terms of the different approach, now I had mentioned before, complementary, integrative. So those terms you could pretty much use interchangeably. There's another term out there called alternative. Now, does anyone know what the difference is between complementary and alternative? So alternative basically means you give up the traditional medical approach and you do something totally different. So for example, this is not migraine related, but let's say someone has a history of cancer and their doctor is telling them this is what you should do. You should do chemotherapy, radiation, perhaps this medication, and they say, nope, I don't want to do that, I'm going to try an alternative approach. So that is basically putting traditional medical therapies to the side. So what I'm proposing is not an alternative treatment. I'm proposing a combined treatment. So you work with your doctor. Yes, you can take medications when necessary, but the goal is to try to decrease the number of medications you're taking and the frequency of your medications and try to be as headache-free as possible. Again, there's no cure for migraine, but there are ways to moderate the symptoms. So addressing the triggers, and the goal is to raise your threshold for headache. So we all have a threshold for headache. Everyone gets headaches. Everyone in their lifetime will experience headaches. So for example, if you don't eat, you may get a headache. If you're very stressed, you may get a headache. So everyone has their own threshold. So let's say your threshold is very, very low. Okay, it's not going to take much of a trigger to give you a headache. But if you can raise your threshold, then it's much less likely that you will have a headache or migraine. So the goal is to, again, raise this threshold. So, sorry, this didn't come out very well. It's a little bit blurry, but here's the threshold. And so let's say someone is experiencing muscle tension, they have work stress on top of that, they have lack of sleep, they've missed meals. So it's gradually climbing up, but the one that broke the camel's back is the hormonal trigger in this patient. Okay, so again, if you could just try to raise the threshold, even if you did have a hormonal trigger, you may not actually experience the symptom. So that is the goal of my approach, is to try to raise that threshold. And the threshold can be changed by both internal and